Good afternoon, and welcome to our third and final webinar in the Boost HPV Vaccination Quality Improvement webinar series. We are so glad that you've joined us today to learn more about strategies to improve HPV vaccination. My name is Shante Davis Patterson, and I'm the program director for California's Comprehensive Cancer Control Program. And we administer the State Cancer Coalition, the California Dialogue on Cancer, or CDOC, which is a co-founder of the California HPV Vaccination Roundtable, along with the American Cancer Society. Today, we're going to be focused on using a systems approach to improve HPV vaccination. So the California HPV Vaccination Roundtable is a coalition of diverse stakeholders with a mission to work together to eliminate HPV cancers by increasing California's HPV vaccination rates. Our goal is by 2035, at least 80% of 13-year-olds in California will be up to date on the HPV vaccination series. And what our coalition does is number one, we convene diverse stakeholders who have an interest in increasing HPV vaccination. We execute high impact initiatives requiring collaboration. We disseminate evidence-based strategies and resources, and we foster connections to help amplify the efforts of individual organizations that are a part of the roundtable. All right, so for housekeeping today, this webinar is being recorded, and it will also be shared along with a PDF copy of the slides to all the registrants and attendees after this webinar, after the webinar. Please use the Q&A box to ask your questions to panelists, and they will respond directly in that Q&A box. And then if you have questions after the forum, you can email the California HPV Roundtable's email box at info@cahpvroundtable.org. All right, CMEs, continuing medical education units are offered by the American Academy of Pediatrics, Orange County. In order to receive a CME, you must have signed in to this current webinar and complete the evaluation that we will post in the chat at the end of the hour. So please make sure you stay on for the whole webinar. And we will also email you that link. So don't worry if you don't catch it in the chat. If you have registered but are currently watching with someone else, please make sure that you sign on now so that your attendance is documented for that CME. Evidence-based systems approaches. So as we wrap up this webinar series, I want to connect today's topic to the first two sessions that we had previously. In those webinars, we were focused on communication strategies, how providers can make strong recommendations using the announcement approach, which was last month, and how to effectively communicate with and address questions from vaccine hesitant families. These communication skills are incredibly important, but communication alone is not enough. Even the most effective recommendation can be missed if the systems around vaccination aren't working well. That's why quality improvement efforts also focus on systems approaches that make it easier for providers to recommend, administer, and complete the HPV vaccine series. These approaches include policies such as HPV vaccination at age 9, workflow improvements like clinical decision supports, standing orders, and vaccination-only visits. Assessment and feedback to help practices track their performance in ongoing provider and staff training, and reminder and recall systems that help patients stay on schedule. When these strategies work together, they reduce missed opportunities, create more consistent vaccination practices, and help ensure that every eligible adolescent has a chance to be protected against HPV cancers. So today's speakers will walk us through many of these evidence-based approaches and share practical examples of how they can be implemented in real-world clinical settings to improve HPV vaccination rates. So let's discuss the benefits to vaccinating against HPV at age 9. There's a higher series completion when series is started earlier. There's a stronger immune response in younger adolescents. There's a more cancer prevention impact when vaccinated before exposure. There's shorter discussions with parents compared to discussions at age 11 and 12 or 11 to 12. And then simpler scheduling with fewer competing vaccines at age 11 and 12, and then reduced missed opportunities. You can also learn more about vaccinations starting at age 9 on the National HPV Vaccination Roundtable website. And I see that it was just dropped in the chat there. So, using data from the California Immunization Registry, or CARE, this table here shows the proportion of kids completing the HPV vaccination series by the age that they initiated the series. So, starting with the cohort of 13 to 17-year-olds who had initiated the HPV vaccine series as of December 31st, 2025, this table shows the age at which they initiated the series and the proportion of kids that completed it. Just to note, 15 to 17-year-olds are not shown because they had much shorter period in which to complete the series compared to the 9 to 14-year-olds. So this supports one of the benefits of starting HPV vaccination at age 9 we listed on the previous slide. Kids who start the series earlier are more likely to complete it. Now, throughout these webinars, we've been addressing these major barriers to immunization, and today we help you conquer the last two by sharing ways to reduce missed opportunities and how to effectively provide feedback. So now, without further ado, I'm going to introduce our first speaker. I would like to introduce Cassidy Boyd, who is the manager in the Population Health Department at the Rady Children's Health and Public Health at Rady Children's Health and a public health PhD student at UC San Diego's Herbert Wortham School of Public Health. Cassidy holds an MPH and has spent over a decade at Rady Children's Health working across clinical research, grants, and population health initiatives, including quality improvement and HEDIS metric-driven approaches. Her doctoral research focuses on applying implementation science and health services research methods to increase pediatric vaccine adherence. Today, she'll share the systems approach her team has developed to improve HPV adherence. And we're so happy to have Cassidy. She's a friend of the roundtable, and I'm going to turn it over to Cassidy.
Thank you so much, Shante. I really appreciate it, and I'll go ahead and share my slides. Just confirming that you can see okay. And I got a thumbs up. Thank you so much for that.
Yes, we see them.
Perfect. Well, welcome again, everyone, and a big thank you to the whole CDPH team for having me here to close out the Boost HPV vaccine series. Today, I want to share with you how Rady Children's used a systems approach, not just a single intervention, to move the needle when it came to our HPV completion rates, and how hopefully you can do the same. I have no financial disclosures or conflicts of interest. So a little about me. I've been with Rady Children's for 11 years now. I've worked in the clinical research department, including on the COVID vaccine trials with Moderna during the pandemic, and did a lot of philanthropic and state grant work over the years. I'm now in population health, where I get to work with an amazing team and serve as a manager and help to lead some of our quality improvement and care coordination initiatives. I just last week completed my first year as a public health PhD student at UCSD. And I get to an opportunity to study where our evidence-based vaccine delivery is meeting everyday practice. Oh, thank you for the claps. I needed that. It was a therapeutic weekend. But using implementation science and health services research is really where the rubber meets the road. And that's a little bit what I want to talk to you about today. So to talk a little bit about the place where this is happening, Rady Children's Health is one of the top 10 pediatric health systems in the country. We care for more than 300,000 kids a year. That's about 92% of the children in our region. And we're the largest children's hospital in California. We've recently joined forces with Children's Hospital Orange County, also known as CHOC, under one parent organization, Rady Children's Health. And here, scale really matters. We can really change how vaccines are delivered and reach a very large share of the region's children. And most of that care happens through our clinically integrated network. Rady Children's Health Network includes more than 60 primary care offices where HPV vaccines are delivered, over 200 pediatricians across San Diego and Riverside counties alone. We've managed financial risk for these populations since the early 1990s for both Medi-Cal and commercial members. And being integrated is what makes the system's approach possible. We can roll out the same prompts, scripts, scorecards across every office and close care gaps together. So why HPV? I know I'm probably speaking to the choir a little bit here, but vaccines like HPV, this one makes a huge difference in patient health outcomes. It prevents 6 types of cancer. That's the headline. But it takes a huge amount of work to overcome the lags that we're experiencing in this vaccine versus other adolescent vaccines because of stigma, awareness, and access barriers. So this is the key idea for today. There's no single reminder or single campaign that can fix all those factors. What works as a system, aligning clinical guidelines, provider behavior, data feedback, and family outreach so that they help to reinforce each other. This is also a really interesting selling point too for that headline when it comes to getting executives and leaders on board with this. Certainly it helps with health outcomes, but sometimes you also need something else to move the needle when it comes to internal bureaucracy. Adherence to HPV and other immunizations offer opportunities for health plan incentives and stronger contracting positions. So being able to take advantage of those regardless of what kind of health system you are really helps to move the needle and be able to help get the support needed to implement a lot of the things that we talk about today. So some quick vocabulary to ensure that we're all speaking the same value-based care language. Value-based care is a bit of a buzzword. It's important that everyone, payers, providers, and especially care teams and families understand how this sausage is made. In HPV vaccination, value-based care means providers and health systems are rewarded for achieving high vaccine completion rates and reducing missed opportunities, rather than just simply being paid for each visit, thereby aligning financial incentives with public health goals. HEDIS is a standardized set of quality improvement metrics, also called the Healthcare Effectiveness Data and Information Set. This is what health plans report on and are held to. It's a really important set. NCQA, or the National Committee for Quality Assurance, is the organization that maintains HEDIS and the sets that those measures actually really measure. MCAS, or the Managed Care Accountability Sets, is the California-specific version of priority metrics that our Medi-Cal plans are held to. And then there's AMP, which is Align, Measure, Perform, and this is a comparable program that functions on primarily the commercial side. When I go on later to talk about the benchmarks, these are the yardsticks that they're measured with. So let's start with one of the many metrics that are in these sets. NCQA's HEDIS and DHCS MCAS both adhere to a set of immunizations for adolescents, or also what's called IMA. In order to pass, an adolescent needs to have 3 things by their 13th birthday: a meningococcal vaccine, a Tdap booster, and the complete HPV series. They need all 3 in order to be considered adherent or having this care gap be closed. If a teen is missing one, it's usually HPV. So that's where the opportunity is to move the needle on health and this larger quality metric that's tied to incentives and contracting. Despite the turmoil at the federal level around vaccine guidance and the consideration of a single-dose HPV vaccination, NCQA is slow to move, and with AB 144, the state has done much to protect the coverage through this requirement of health plans. In addition, insurance plans see it in their best interest to continue to have a vaccinated membership, so those things really haven't changed. During the public comment section for the next measurement year, they call it a measurement year, it's really a calendar year, The major updates shared from NCQA were around data streams, getting more electronic reporting, nothing regarding changes to well-established metrics such as pediatric vaccinations. Still, we should be cautious. Historically, NCQA will monitor, then evaluate CDC guidance, then post public comment, and then finalize in following HEDIS years. There still could be shifts and updates late in 2026 that could affect the following measurement year or calendar year in 2027. One possible shift with IMA could be that the numerator would change from completed HPV series to maybe one or more HPV doses, with meningococcal and Tdap thresholds unchanged. So what we all need to be watching for is NCQA's measurement year 2027 technical updates. Those usually come out in August or September for official confirmation. In addition, state level variations could address either keeping consistently or change coverage and requirements that would emerge as part of the MCAS set, which is really what's in the driver's seat for plans and providers here in our state in California. So here's what good looks like as defined by NCQA. The minimum performance level that plans and providers are held to is the 50th percentile. That's this guy right here. Roughly 34% for Medi-Cal, and then the 66th percentile right here when it comes to commercial. These benchmarks dropped about 2 percentage points from the previous year. This indicates a national downward trend that's contributing to a lowered goalpost for us all. But that doesn't mean we shouldn't try to exceed it and get into that 90th percentile as often as possible. A few rules that trip people up with this metric: it takes 2 to 3 doses depending on age for HPV, and the first 2 doses have to be at least 176 days apart as defined by NCQA. The whole series has to be completed between the 9th and 13th birthday. That last rule is exactly why starting early, like what Shantae was talking about, really matters. Starting at 9 gives you a longer runway to land in. So how do we actually make movement on this? We've built our work around 4 major pillars. First, guideline-driven care, starting the series at 9, and having our EHR support that, our electronic health record. Second, provider training, how teams across San Diego and Riverside are talking about HPV. Third, assessment and feedback, showing the offices their own numbers, making sure that they understand how they're performing. Fourth, care coordination, proactive outreach to families by people who can meet them where they are. None of these things work alone. The gains really come from doing all 4 together, and I'll walk through each. So starting with our first pillar, beginning at age 9. Research in Frontiers in Public Health 2025 show that 9 to 14-year-olds develop higher antibody titers and greater levels of protection against HPV-related diseases than older adolescents. And in a 10-year follow-up study in pediatrics from 2023, they were able to demonstrate sustained immunogenicity and effectiveness in approximately 10 years post-vaccine in children vaccinated ages 9 to 15. All this to say, starting at age 9 really works for the long haul. Starting earlier also means you have more kids finished by 13. And if they start before 15, they only need 2 doses instead of 3. We made this the default with care gap information in EPIC, our electronic health record system, which is clearly displayed on the medical record front page for easy access by everyone in the care team. We also use a system called REDCap, traditionally used in research to be able to collect survey information and qualitative and quantitative information. But here we use it as a workflow system, and the team of patient care coordinators, who I'll get into in a little bit, get a notification that flag kids who are turning 9 so that they can reach out when it comes to their well child visit and make sure that they know that they can start getting their HPV vaccine. So much of behavior change is about removing barriers and making the easiest thing also the best thing. Pillar 2 is a lot about how providers talk. The announcement approach, which I know you've heard about before in this series, means using a presumptive statement. Your child is due for HPV today, instead of an opening debate. This approach was evaluated in a randomized clinical trial in 30 primary care clinics serving 17,000 adolescents and is now housed and disseminated through HPV IQ, which is a University of North Carolina-based resource center. It treats HPV like any other routine adolescent vaccine, and studies have shown that this simple change raised same-day uptake, especially when you can focus it around a cancer prevention conversation point. Of course, some families still hesitate. That's where motivational interviewing comes in. A conversational style where you listen, affirm the parent's role, and address their specific concerns instead of lecturing. The credit for this system goes to William Miller and Stephen Rolnick, who developed the evidence-based counseling method in the late 1980s to early 1990s for promoting behavior change. It respects families' autonomy and builds trust over repeated visits, and it complements the announcement approach. It does not replace it. Operational trainings as well, such as policies around scheduling the next dose before leaving the office, how to understand care gap reports, and identifying open care gaps are critical to applying both the announcement approach and IMA in partnership. Pillar 3 is all about data feedback. Every month, each provider gets its own HEDIS and AMP scorecard, plus a list of kids who are due or overdue for HPV, all the other immunizations, and metrics as well. Thanks to members of the team pictured here, who are the amazing group I get to work with every day, we are able to review network and office level numbers quarterly and focus extra help on the offices who are lagging. People change behavior when they can see their own numbers against those national benchmarks that we were just looking at. Physicians especially love to be straight A students. Who doesn't? This is especially so when their efforts are acknowledged through incentives earned through performance from health plans. Pillar 4 is where the patient care coordinators are, and this is really the heart of the work. When examining a year-over-year comparison from years from before we had staff dedicated to this work to today, we've seen a statistical significance in the number of children who complete their well child visits. This is, of course, where they're most likely to get their HPV vaccine. PCC's outreach using MyChart, a patient-facing secure messaging system hosted in Epic, the phone, and now we're piloting text messaging to meet families where they are. The team includes staff who are native speakers of English, Spanish, Vietnamese, Russian, and others, along with our translation line. In Epic, they can pull care data, like what Shantae was talking about earlier, directly into the record so we can capture the vaccine status, even if they don't get it from us, maybe Walgreens or somewhere else. While staff are working with patient families to schedule, they're also screening for social drivers of health, such as housing, food, and transportation insecurity. More families and a lot of providers don't realize that Medi-Cal plans are required to offer transportation support to their members. It can look different depending on the plan, everything from bus tokens to Uber vouchers and drivers, but helping families address these barriers increase the likelihood that they will actually make the appointments that they're scheduling. Tying all this together is Quality Improvement Engine. A Plan, Do, Study, Act, or PDSA cycle is a well-established system to be able to evaluate interventions throughout a larger process change. And a PDSA cycle means that you test a small change or a large change and see what happens, and then scale it up if it works or scale it back if it doesn't. Ours included staff education, building dot phrases, which are kind of like default template messages in our Epic electronic medical record system, scripting using the same EHR where documentation occurs, so the right words are only a click away, and using those quarterly scorecards, now monthly scorecards, providing touch points with families and providers to be able to help counter misinformation and find the next problem to tackle. And every QI project needs a clear target, a SMART aim, being able to make sure that it's scalable, measurable, timely, meaning that it is really looking at what can you accomplish within a reasonable amount of time. Ours was to increase HPV completion among 9 to 13-year-olds Medi-Cal members in our network by 3.27 percentage points, from 32.3% up to 35.57% benchmark from July to December of 2025, following that calendar or measurement year. Here's the results on a control chart, which track our monthly rates against upper and lower control limits. So you can see this red line here is the increase throughout the year. Up is better, that's why that arrow's there. We've got our lower confidence interval here at 28%, upper confidence interval range at 38%, and this target, 35.57%, was identified as the 50th percentile for HPV vaccination during that measurement year. And you can see our center line right here at the 33%. And I suspect there was a minor center line shift, but it is a narrow one, so you don't see it necessarily captured here. We started with the year with a baseline around 26% below the lower limit, which you can see each intervention along the way, patient lists from plans, outreaching to non-compliant families, quarterly scorecards, and others. The line climbs steadily and crosses our target, and the pattern of sustained shift, not just random noise, really tells us that the change is real. So to put some numbers to it, for those Medi-Cal patients turning 13, we went from 26.4% baseline in January to 36% by September, which was before our goal of doing so by the end of the calendar year. This was a 9.6 percentage point gain, which surpassed our 35.5% aim. Where the previous measurement year in 2024 ended in 32.23% compliance, this was a big jump and it held. But you might be asking, what about all the other years? This is the analytical backbone behind those results, and a big shout out to our analyst team here in the Population Health Department for being able to pull this information and be able to allow us to look between years. This year-to-year comparison of IMA HPV and IMA Combo 2 composite from 2023 through this May. Here you can see each year, of which we're currently in 2026, which is why this is grayed out because it's not completed yet. And you can see IMA HPV, which is specifically HPV in the dark blue here. And then for the whole IMA composite, which includes meningococcal and Tdap, in the lighter teal here. So two takeaways from this data. First, the jump from 2024 to 2025 was statistically significant for both measures, about a 4.5 point gain. And the control chart flagged it as a special cause variation, meaning that the real process change happened, not just random noise. Second, HPV and combo 2, you'll notice rise together and fall together, which confirms that HPV is a key lever in this composite metric and really drives the other two, which makes sense. Tdap and meningococcal have other requirements outside of, HEDIS and, primary care. We've got schools to consider, other requirements. A caution worth noting, though, however, the move to an electronic or e-measure by NCQA for IMA left the end of 2025 and the start of 2026 as partial years. So we do read these levels very carefully, but the directionality and the statistics line up across every method. Encouragingly, early 2026, where we are now, and this is measures as of May, are above prior years. So the gains look to be sustaining. For those patients who are starting their series earlier, come their 13th birthday, are more likely to be adherent. So if you take one thing home from all this, it's this. There's no single lever. Aligning a bundle of evidence-based interventions increases sustainable outcomes. It makes making the easy choice the default choice by starting at 9, announcing presumptively, having scripting in place makes a huge difference. Letting your data drive feedback and drive your outreach not only creates a narrative, but it also really helps you make decisions in a more productive way. And with those PDSA cycles, being able to look at the data iteratively will allow you to see how those interventions are landing with your specific population. That's how quality improvement turns a guideline into a completed vaccine. I hope you find this playbook replicatable in your own systems. I'm very happy to share more about any of the tools that we talked about today, as well as any others. I am an open book. I have my contact information on here, but I really want to just say thank you so much. I'm grateful for my team here at Rady Children's in the Population Health Department at Rady. the faculty at UCSD School of Public Health, the CDPH team, and to all of you for being a part of this series. Having the people on here, we've got 163 participants today. You being a part of this is going to be what moves the needle. I'd love to save a little bit of time to be able to take some of your questions.
Thank you so much, Cassidy. That was excellent. Let's check the chat to see if we have any questions in our Q&A box. Okay, I don't see any now. We do have a minute or so if anyone wants to come off of mute. Please feel free to just come off of mute to ask a question if you have one. All right, you can still drop any questions you may have in the Q&A box while we're still on the webinar. Thank you again so much, Cassidy. All right, so now it's my pleasure to introduce our next speaker, Leanne Alarid. Leanne is a local care representative for Los Angeles County and has a master's in public health from UCLA. During her time at CDPH, she has participated in the HPV Vaccine Roundtable and Coalition. And outside of work, she also enjoys spending time outdoors with her dog, Huey, cooking and going to the movies. So it's my pleasure to turn it over to Leanne now.
Good afternoon, everyone, and welcome. Thank you for joining the webinar today. Thank you for having me. So I'm going to be presenting briefly today on care and how it can assist you all with contacting and conducting reminder recall for those patients that are due for HPV vaccine. Next slide. So just to start off by mentioning, I have no financial disclosures, and then just some background on some of the data elements specified for the California Immunization Registry law. So patient reporting requirements ask that you all include key patient demographic information, including the full name of the patient, parents, and or guardians, the patient's date of birth, current address and phone, gender, race, ethnicity, and other non-medical information that may be necessary to establish unique identity, like mother's maiden last name, birth order if they are multiple births, or AKAs if they have alternative names. The newest feature in care or newest field in care is sexual orientation and gender identity, or SOGI, you might hear it abbreviated as. And that's where you can specify an adult patient's SOGI information if they choose to disclose that. Also, for care, we ask that you always document the types and dates of immunizations received for your patients, including the manufacturer lot number, adverse reactions if they have any, and then results for TB test screening. If you have any additional questions about these reporting requirements, we do have resources from the CDC via these QR codes. Next slide, please. Okay, so we're going to move on now to a brief care demo. So I'm going to go ahead and share my screen. And you all should see on your screen the care system. So just as a heads up, this is our training server. So the patients we are going to be looking at today, they are all fake patients. They are not real. This is just the server that we use when we do our care user training. So the first thing I want to show you all, when you have a patient that is due for HPV vaccine, we're going to go to patient search. And I'm going to log back in because it logged me out within the last 15 minutes. If you all are familiar with care, it does that sometimes. Oh. Oh no. I'm spelling it wrong. Sorry, all technical difficulties. So for our care server, when you go to the login screen, we're going to search for a patient who is 9 years old. So I'm going to search her by care ID. And the patient we're looking for, when we open up the record after you verified the unique identifiers that this is your patient, and you verify again via unique identifiers. When you go to see what vaccines they're due for, you're going to click on History Recommend. And we note that this patient is 9 years old, so they are now currently eligible for HPV vaccine. And CARE is going to give you an alert for those patients that this patient is now eligible for the earliest date, and with a button to dismiss the alert. If you click Dismiss Alert, it will not appear again for your clinic or for any other provider clinic. So we do recommend to leave the alert until that vaccine has been administered, and then you would document as you do in CARE or in your EHR if it's connected. But the other helpful feature of CARE I really want to focus on today is Reminder Recall. So if we go to Reminder Recall, this is in the reports section of CARE, and it's a report that you can use to determine which vaccines or which patients are currently due for specific vaccines. And the way you would run the report is typically you would use Create New Report Criteria. I'm going to use a previous one because I have already run this report, but it's going to show you, you would designate it, what vaccine you're looking at and what age group. And then I like to make the report name as the month that we're running the report. So we're going to switch this to June 2026. And then if we scroll down, we're looking at all of our patients. So you would do this for your clinic. Select patients with any contact information. So this could be phone number, address, or email address. And then tracking schedule, the default is CDPH. This is based on the CDPH and American Academy of Pediatrics recommendations. If we scroll down, you can select the vaccine group. So today we are interested in looking for patients due for HPV, which, why is it not showing up here? Oh, it already is. There we go. So if it was not appearing here, you would click Add, and it's going to go from this side to here where it's selected. We're going to exclude any flu vaccines, and we're going to look at patients that are both due now and past due in the age range of 9 to 18 years old. So when we click the report, you all are going to click Save and Generate. I'm not going to click this because CARE only saves one Reminder Recall report, and sometimes it takes a few minutes to run. So I already have one set up for us to look at. I ran a few days ago. You'll notice the date is the name is a little bit different, but we are looking at 51 patients between age 9 to 18. And when you run Reminder Recalls, you have a few different ways to generate the output. So you can see how many patients are associated with your clinic, how many patients you're looking at. So 72 are within that age range, 55 have contact info, and then 51 of them are now due or past due for HPV vaccine. So it shows you how it gets to that number. And there's a number of different reminder options you can do. So you can send them reminder letters, reminder cards, mailing labels, patient queries, etc. And there's also free text here where you have the option to type in information for the patient or the parent that you're going to send to. So if you want to type something like, please call our clinic to schedule an appointment, and then you could put your phone number here. I'm just going to put 1, 2, 3, 4, 5. But you would click this, and then when you generate the reminder letters, it's also going to show you reminder output status. If it doesn't start as ready, you might have to refresh it a couple times. But this is going to show you different letters. So for each patient with their name, what vaccines they are currently due for, or no, what vaccines they have received, and then which vaccines they are currently due for right here. And then the free text message that you enter, it's going to appear here at the bottom. The number for our office, that's the one that we entered. And then this is the free text message. Please call our clinic to schedule an appointment. And you'll get a long list with one page for each patient that's due. So you can send these in letters. And then closing that out, I also want to look at the reminder card. So it's going to look very similar, just in a smaller format. So if you want to print out postcards for the patient, you can do it this way as well. Or if you would like to use, just generate a list. Another really helpful feature is the patient query listing. So this one, patient list, is helpful for you all as provider, or for providers. It's going to give you a list of the patients, which vaccines they have already received, and then which date, along with which ones they're currently due for. So lots of different ways that you can use Reminder Recall. There's also features to generate the mailing labels for their addresses. And then finally, the review patient at the bottom. I also want to point this one out to you all as the medical providers. You can get a list, like a summary list that you can export into Excel of these patients that are due for the HPV vaccine. So lots of different ways to use Reminder Recall. I hope that it can be helpful for you all at your clinic. I do also want to briefly mention, along with Reminder Recall, manage patient status. When you run a Reminder Recall report, sometimes if you have a large volume of patients, so if you're a large volume clinic, there may be certain patients that they've been to your clinic in the past, but they have not been back in several years. Care is going to still consider them as your patient unless they're inactivated. So we do have a feature, Manage Patient Status, where you can generate a list of patients that are that haven't been to your clinic within a specific time frame, or that haven't received an immunization from your clinic within a specific time frame. So maybe they haven't been back in more than 2 years, and you want to inactivate them. So they're not counting against your coverage rates, or you're not generating Reminder Recall reports for staff or for patients that are no longer at your clinic. So Reminder Recall, Manage Patient Status. We do have user guides for both on our care website, and you can also reach out to your local care representative if you have any questions or need help with this. And then one final report I'm going to show you all that if you've taken the care training, you might already be familiar with. It's called the Doses Administered report. This report is going to generate a list of all the vaccines given by your clinic within a specific funding source and date range. So if you're a VFC provider and you just want to look at VFC, this is a good option. I'm going to leave it set to all. And I actually already have a report generated. I'm going to just pull it up on our screen. But this is what the report will look like when you enter the parameters. So we're looking at a very wide date range since this is our training clinic. We don't give too many vaccines here, but this would be the date range that we're looking at. So we're looking at for a little over a year. And we can see all the vaccines given by our clinic. We see a handful of HPV with additional information about the patient that received them. And then there's also an option to generate this report as an Excel file. So I'll pull up what that one looks like. And if we look at the Excel file, it's a little bit more helpful because we can narrow down the vaccine groups. So we can see just the vaccine groups that are HPV-9, and we see those specific patients that received the HPV vaccine. So these are the patients that they did get vaccinated, whereas Reminder Recall, those are the ones that are due for vaccine. But this is going to wrap up the care part of the demo. So I'll go ahead and stop share. If Joyce can go ahead and resume with the slides. I have just a couple more slides with some care resources. So our care website, cdph.ca.gov/care, you'll find all of the guides and videos, LCR contact info, help desk information there. And next slide. And one more time, sorry, you might have to click this one if you. We have our guides listed. So based on what we talked about today, you all might find the regular user guide, Manage Patient Status, and Reminder Recall guide helpful. We do also have a few training videos on Manage Patient Status and Reminder Recall. The videos are a little bit older. I would personally recommend the guides. All of them are up to date and current. And then if we go to the next slide, we have some final resources for your LCR contact information. You can check who your LCR is for your part of the state. If any of you are in Los Angeles County, I'm one of the LCRs for LA County. And then if you have more provider, like vaccine general and questions, you can reach out to the provider call center. They have a phone and email. Care help desk is more for like password issues or technical questions. And then if any of you have your EMR connected and you ever have questions about your EMR or data exchange, you can reach out to our care data exchange specialist. But this concludes my section of the training. I'm available if any of you have care questions.
Awesome. Thank you so much, Leanne. We do have some questions in the Q&A box, so I'll just go ahead and read them. Is CARE going to update the recommended date for the HPV vaccine to the child's ninth birthday? Currently, the recommended date is the child's 11th birthday. While the earliest date is the ninth birthday, some clinicians may overlook that date. I also noticed the second dose does not display the minimum interval of 5 months as the earliest date.
So that's a good question. I know there's been discussion about changing the like notification. It There just hasn't been any update up until this point. For the time being, I think it is going to stay at 11. That's a question that's a little bit above my pay grade. I can't make the decisions for that, but I think the workaround was the little notification letting them know that it is eligible. So if your clinic does offer the vaccine at 9 years old and you give it, it should count as valid in care. But I can report that the note about the second dose not being recommended or it's not showing the interval. I can go ahead and report that.
Right, thank you. There's another question that says, is it possible for one person in an organization to have the ability to run reports for all of the clinics?
Yes. So yes, with a caveat. So all of the clinics do still need to have their own org code. But if you have one, like a manager that works amongst 5 different clinics, as long as they set up their care account so they have access to each location that they work at, they can run the reports for all of the locations. And if that's something you need help with, setting up like the manager or the point person that's going to be running those reports for multiple sites, your LCR can help you with that.
Great. And then I think this is just a comment. This is a great refresher. We are having trouble as most all care user accounts are no longer regular users. They are now read only. With that, we are unable to run these reports.
For read only, so if your clinic is set up at data exchange, that might be why you're limited to read only. I would suggest seeing if your manager can submit an account update and change you to the QA. So it's short for quality assurance. It's very similar to the read only user role. You don't document anything in care, you can't make edits, but you will have access to the report as QA versus read only.
Great. Just want to check to see if there are any other questions here. Any other questions? Right. I don't see any other questions in the chat or in the Q&A box. All right, well, thank you for fielding those questions, Leanne. Okay, so just as a reminder here, to receive a CME for this webinar, you must have signed into this current webinar and complete the evaluation that we are posting in the chat. We will also email you a link after the webinar. And thank you for joining us today and for making HPV vaccination a priority. We're so glad that you chose to join us for this webinar series, and we hope that you found all of the sessions that we offered informative and inspiring. For any questions, just remember our email for the roundtable is info@cahpvroundtable.org. And with that, this concludes our webinar. And I again want to thank our presenters, Cassidy Boyd and Leanne Allred, and all of the organizers of this whole entire webinar series. Thank you for joining us.
Thank you.
Thank you all.